Good morning, everyone, and thank you again for joining us for our Person and Family Engagement Community of Practice event. This is Katie Rees, so one of your HIN PFE leads, and then we'll also be joined by Stacy Klinker. So just a few housekeeping items. We want to know who's in the room today. So we can kind of see who's on here with you, but sometimes we don't get to see, we get a call-in number, or we just get to see part of a name. So if you could please, in the chat box, type in your name, facility, and your role. We'd love to know who you are, and we've kind of got a little bit of a smaller group today, so we might call out for some of you guys to kind of get some of your thoughts on different things as we go through them. But we also really want to encourage you that as we go through today, if you have questions, that you can chat that into the chat box. We'll be watching that as we go through, or take some notes, because we'll also open it up at the end and kind of get some feedback from you guys. As a note, though, we will go ahead and keep everyone muted today. As we go through, there will be moments when we unmute our line. So if you can please just make sure that you are watching your line, and if you want to make sure that you're muted, if you've got someone else that's popping in, or perhaps you're typing at the same time, we know that happens sometimes. So please just take a moment to make sure that you're muted and there's no background noise. Please do not put us on hold, because as much as we love your elevator music, everyone else can hear that too, and it makes it difficult for us to kind of continue on and for people to hear what we're saying. So, and again, we just encourage you to make this an interactive discussion. So post questions if you're having a PFE issue, if there's a big pressing matter, or anything you might be thinking about or looking at already, put that in that chat box, because we want to hear from you. So what I'm going to do now, I'm going to turn it over to Stacy Klinker, and she is going to go through and give us kind of a recap of our previous community of practice events and kind of where we're at right now with our PFE, and then as we kind of dive in to start looking at what can we do and how can we capture our success. So Stacy.
All right, thank you. As you remember, in July, we heard from Tom Workman, and he kind of discussed a little bit with us about the individual metrics, what they mean, how to meet them, maybe some alternative ways to meet them, and really the intent behind them. He also noted that there was a language change with some of the metrics, and even though that language did change, the intent behind them really stayed the same. So if you missed it last time, I really encourage you to go out to Innovation and check that out. We have it posted there. It was full of a lot of really useful information. Next, we'll take a look at our PFE progress specific to Compass HIN. We really want to acknowledge that we have made good strides, but we have work left to do. We're going to talk a little bit about where we were in HIN 2.0, where we are today, and then kind of look at how we compare to the other HINs across the country. So in HIN 2.0, you can see there, as of March of 2016, those were our standings for the metrics: 41.5, 73.5, 50%, 46.2%, and 43.4%. Those were for our Iowa hospitals. And then for South Dakota hospitals, you can see there in the yellow is our Q3 numbers. We have 16%, 39%, 32, 26, and 37. So that's kind of where we were at leading into HIN, which brings us to where we're at today. Currently, this is where our performance stands with our PFE metrics. You can see we have 58%, 58, 43, 38%, and 38%. We've seen an increase in metric 1 and a slight decrease in the rest. And that tells us really one of two things. Either we've stopped doing some of those things that we were doing in HIN 2.0, or we're not accurately capturing all of that hard work that's still currently happening. So that's something to keep in mind as we move forward. So next, we'll kind of take a look at, this is our comparison as Compass HIN to the other HINs nationwide. You can see we have pointed out for each metric where we kind of rank in each of the standings there. There's PFE metric 1 and metric 2, and then our progress for metric 3 and metric 4. And then we have metric 5. So that's kind of something to keep in mind as we move forward here. And I'm going to turn it back over to Katie, and she's going to take us forward.
Thanks, Stace. So as Stacy mentioned, we look at our performance, and even if we kind of go back here and we look at where we're ranking currently with our other HINs, and we look at our performances in there. So what are some thoughts that we have? So Stacy mentioned before that did we stop doing some of the things that we used to be doing? What are some current considerations for our status in PFE right now? And one of the things we want to acknowledge and call out that there are competing priorities. There's a lot of work that we're all doing. We have a lot of clinical imperatives that we are working on day in and day out, and in that acute setting that sometimes feels like they kind of take precedence. So one of the things we want to call out, and we want to acknowledge that. So one of the things we want to look at and say, all right, so are we doing PFE specifically and calling it that? Or are we working on something else and maybe PFE can be integrated in through that, and we're just not capturing it because we're calling it COTI? Because we're not specifically identifying that it's its own standalone person and family engagement effort. Are we missing that? We also want to acknowledge those mixed understandings and interpretations. We know when Tom joined us the last time that we've had some updates in the language of the metrics. The important thing to remember with that, and Stacy will go into some more of that in detail as we kind of progress together, is that the language is not a catch-all. That language was kind of short and condensed just to add some clarity and some confirmation. But what we really want to focus on is the intent of those metrics and how do they fit for us? What does that look like? And that's why when Tom joined us, he offered us those acceptable alternatives, those things that say, okay, so it may not meet the metric in its plain blank out language that's in black and white there, but really does it meet the metric because it's looking at the intent and we just weren't reading all the little, do you have a PFAC? Parentheses, or if you don't have a PFAC, you have this or this or this in place that is really hitting the intention of what that metric is looking at. We also know we have variant visions and inconsistent commitment. Again, and this is just an acknowledgement and not to call out any negative, but to know we work in a real life situation. And sometimes we look at PFE or we look at the roadmap, a lot of it looks very idealized. So we want to call out what real life looks like, and sometimes that's that variant vision, to recognize to say, you know what, we only acknowledge PFE if we had a really big campaign, or if we can call out that it's in every single place with every single patient at every single time. And really, in patient-family engagement is so much more than that, and it is the little tiny steps. It's an episode. It is a single event that occurs, and then everything that kind of leads up to that being a process and being systematic that's in there. We also know when we have so many competing priorities and we are in the depths of healthcare transformation, that even getting the commitment and the leadership buy-in or getting physician champions on board, we can go through phases and cycles where we've got all that in place and then some other burning fire emerges, and so it makes it difficult to maintain that momentum. So being able to acknowledge and call that out is really important, because when we acknowledge and accept that, we can figure, okay, so if this is something that's happening, how do we need to go around that? So is the issue with our PFE, and maybe the issue is maybe we're not doing as much as we were doing in HIN 2.0. And that could be acceptable. That could be completely understandable, just given that general cycle of change, that ebb and flow that happens. The path to progress and success is not a straight line. And so we anticipate as we navigate that, there might be some foundational pieces that when we stop paying attention, we might lose a little bit. And so we need to be working on that and kind of following back. But by acknowledging those things, can we look at, all right, so if we're having an issue with CEO engagement, how do we need to frame the PFE story? How do we need to make that business case, show that return on investment? The other component of that is that recognition of unformalized work. A lot of times we get caught up in the names or the titles where we don't have anybody with the title for patient advocate. So we don't have one. Versus recognizing that the quality person is actually informally your champion for that, the one tasked with doing those roles and those activities, or it's something that's shared across your unit. Those are all things that are person and family engagement, even if we don't call them out by that. So I think it's really important for us to acknowledge that unformalized work. As an example, we actually had a community of practice of that where we were talking about patient advocates, and we had one of our attendees that typed in and said, you know, I'm kind of the unofficial person, but we don't have anybody hired for that specifically, or it's not in my title, so we don't check the box for metric 3. And we actually had to turn back and say, you know what, actually, no, you would check the box for metric 3. You're meeting that metric. You're following in line with it, just because it may not be its own standalone position. And that's why it's so important to look beyond just the one-sentence descriptors for those metrics. Get to the intent of those, because, again, it's about the actions and those efforts more than checking that box. that's going to lead to those improved outcomes for you. And then again, that's part of that reiterated concept of we focus on the perfect and we miss the progress. We wait until we're all the way down, almost at our destination, before we look back and acknowledge this amazing journey we've taken and the steps that got us to that end point. But what we really want to do are use these metrics as they were intended, which is to kind of be a stepping stone and to show that progress in those processes. Okay, we're doing this, 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 and this. Now, it's not perfect. Maybe we're doing it only in one unit. For some of our critical access hospitals, you don't have a lot of, pre-planned admissions, but do you still have a pre-planned admissions check, like a checklist to use when that situation arises? Do you already have that proactively? Because even if you're not actively using it, but you have it in place and you're ready should that circumstance appear, you meet that. And you're actually being more proactive than even the general metric that, for some of those hospitals that might have that, they're checking that. They're doing that because they have to, because that's something they're dealing with right now. But remember that this is about a culture and the shift in how we design care around people to better support our practitioners, our providers. We're looking at reduced burden and a team-based care approach that includes that patient and their family members. So when we think about person and family engagement, I really like to call it into that three-prong approach that really talks about the progression and the process for it. We look at involving patients and families at the point of care, those single episodes. When we look at some of our PFE metrics and we see some of our folks, we're not hitting yes that we're talking at the bedside, or we're having shift change discussions that include the patient. I think about that, and I think back to my experience in the hospital, and whenever I go to a hospital, I'm kind of watching what they do. We do a little observation. I'm always seeing the nurse standing there at that side of that bed having that conversation, or having more of that inclusive discussion. So are we having those conversations with our patients every day? I would venture to say, yes, we are. Are we talking to their family members? Are we having those conversations informally maybe and just not calling them out? Yes. And that's the key area. We want to make sure that just because we're not putting a name or a title on it, that we're not discrediting the work that we're doing. And then that's where we kind of go with patients and families as advisors. How do we integrate that into that process and take their experience and build that into how we design and we look at things? That's when we look at PFE metric 3. We look at a quality improvement effort. So bringing the people in, PFE metric 3 and 4, when we look at PFEX or quality improvement teams, and we look at if you have a champion in there, maybe that champion is the one that's maybe asking some more questions one-on-one with people, or they're calling some of those different folks out, or when you're doing a floor redesign, even of a unit, to where you're going through and saying, okay, how does this kind of work? What might that look like? What would be the flow with that? It's maybe not always a formalized process, but it's just having anecdotal conversations and getting that feedback and input, which is important to capture. Now, do we want to make sure we have a process so it's not just this one time that one thing happened, and we can build off of the momentum and that success and what we know our patients can offer? Of course, but let's not forget about the process that leads us to get there. And then again, most of us are community hospitals. We have a commitment back to our communities about building healthier communities, healthier patients, healthier families. And how are we really going to be able to achieve and do that if we try to silo it between the walls of our practice? It really takes us expanding beyond that. And that's, again, I think, especially when we talk about leadership and engagement and buy-in, bring everything back to our mission and our vision. If you ever have an issue with getting someone to see the value and importance of PFE, even before you go into the effort and the nitty-gritty of getting into the details of here's the total cost of care and here's the impact on clinical quality measures or readmission, tie it back to that mission and vision first. Have that be your first step, just again to kind of frame that shared mental model and that vision. And we talk about the cycle of change, and what we really also want to talk about is even the progression of person and family engagement. When we talk about PFE, engagement is not that end game. What we're really looking at is getting patients to be interactive, engaged, and then to feel empowered and then activated. So not only is it something that they will accept the invitation when we ask them what's going on, but they will share and they will tell us. So if we're standing there at that bedside and we're having an issue with that conversation, we're trying to explain new medications or discharge, that they're not just going to wait until we ask them if they have a question about X, Y, or Z, that they might say, hey, maybe I missed this, but I don't quite understand that. What would that be like? Or who would I call if I did this? Or they would even call back and reiterate back to you and say, okay, so this is what I'm going to do if this happens. Those are all small processes that we don't always take for granted. We see them every single day, so it feels just like an everyday occurrence. But it's important for us to see that progression. And I want to call out the fact that when we do those things, it leads to that activation. So that bedside report leads to the fact and that communication, that conversation, to that greater engagement, that greater empowerment. And so if you ever do get to the point, and for some of us that have our PFACs, and maybe you're looking at starting one and recruiting, or maybe you're looking at retention, then they're more activated. They're more willing to say, oh, I'd really like to be involved in that. One of the patient advocates and representatives from within our own Compass HIN, who's spoken with us, Allie Wolfcolt, who is a patient representative with Mary Greeley, will tell you how she got started in that process to be a patient advocate with the hospital was from the conversations that started at that point of care and how that progressed and what that meant and the progression of her care processes. So the other thing that I think is really important to call out, I know this is kind of in a straight line, but it's never a straight line. It is a cycle, and patients are going to cycle back to each one of those areas, and that's why it's so important for us to have those systems in place to make sure that, again, that how we do this is how we just do business, and it makes the right choice the easy choice every time. But it's also something that I call out for us to recognize that there are going to be times when we do our PFE progression where even if we're high performers, we're going to falter, we're going to teeter, something's going to get a little lost in the mix. So make sure that we're following back in that cycle and we keep that patient and this PFE progression for their activation in mind as we design those things. So the impact of PFE. One of the things we really want to focus in on is, again, PFE should not be a standalone. While we have metrics and we have individual things, PFE really factors in to everything that we do. It really is the key determiner a lot of times in how we're even going to improve our clinical outcomes. And most of our hospitals, we know that our clinical, that the work that we're doing evidence-based medicine. We're getting some of the best technology and we're looking at the best medication. But even when we do that, we only have a locus of control of 20 to 30% to really impact that person's health. We also know that we have limited time with folks. And so what they do after we leave the room or when they leave the hospital is imperative to their care afterwards and whether or not they have a post-surgical site infection, if they have a readmission. So one of the things we want to look at is the fact that going through some of the work that's here is that we have been able to show that PFE impacts these other high priority issues. So if your hospital is looking at readmissions and you're trying to connect it back to those aims and to what's actually at your bottom line, activated patients are less likely to have a readmission within 30 days. So you look at that, a less activated patient was almost 30% more likely to be readmitted to the hospital. And we look at our bottom line and we look at the fact that if they come back in for a readmission within 30 days, are we going to get reimbursed for the care that we have to provide for that to make that person healthy again? And in most circumstances, we're not. Our hospitals are going to have to quote unquote eat that cost, which really impacts when we are looking at if we're going to be in the red or we're going to be in the black. Experience of medical error. Activated patients were almost 20% more likely to be able to be part of their care team and call out a potential medical error. So when we're looking at our adverse drug events, when we're looking at those different things, having that extra set of eyes and ears that can call out, or it's not even just going through and saying, oh, I think they gave me the wrong med or this is happening. They can recognize a change in symptoms. They feel more empowered to say, I feel different about this, or they gave me my medication earlier, rather than just assuming that their role is just to lie there and have somebody administer things to them, rather than be part of that process. Poor coordination between healthcare providers. Less activated patients are more likely to have less coordinated care because they're not speaking up, they're not calling out, they're not supporting in that team. Suffering a health consequence because of poor communication among providers, that's a go-getter right there. We look at almost 50% of patients who are less engaged and less activated having poor outcomes. And that, again, is something that not only affects their experience, their satisfaction, and their overall quality of life, but when we're talking about making the business case for this and a return on investment for our efforts, because we acknowledge that we have limited resources, whether that be time, personnel, money, any of those different things, that's where that makes a huge impact and where we can make the business case to say, hey, this is where it fills in. And so maybe our priority right now is readmissions and CoP, but maybe if we're not moving that bar very much, is there something missing? How can we bring the patient in there? How can we center it around that person who's really at the hub of all those activities? And then again, the loss of confidence in the healthcare system. And that is, again, when we think about discharge and readmission, or we kind of go through, unnecessary testing and procedures, that's huge for that, because if they don't have confidence, then they're going to be seeking out other care. They're going to keep coming back. They're not going to follow with a treatment plan. They're not going to make sure that they have that support network at home to support them. So those are all key things when we talk about PFE that are really important. And beyond even those national kind of general figures that we're looking at, even within our own Partnership for Patients HIN network, we have realized the clinical impact of PFE. So emerging data from the HIN 2.0 and the analysis that the American Institutes for Research and with our partners such as Tom Workman have been showing that hospitals with higher levels of PFE activity, and they define that as hospitals that are achieving at least 3 of the PFE metrics, are showing substantially higher reductions in hospital-acquired conditions or adverse events. So when they're looking at that, they're looking at those with a score with the range, again, of that 0 to 5, and they're looking at those Z-scores in 7 adverse event areas. They were able to show that those high performers for PFE had higher clinical outcomes for the venous thromboembolism, pressure ulcers, injuries from falls, their COTI, early elective deliveries, other OB harm, and then also their VAP. So when I look at this, not only am I saying, oh my goodness, look at this impact of the process and the procedure that we're doing. This is PFE is not just another siloed activity, but it's a best practice within everything that we're doing. But it also helps me to say, okay, so maybe one of these areas is one of those priority areas. I can get the rest of my team on board. Maybe their ears don't perk up when I first start talking about PFE, but maybe their ears start perking up when I talk about one of these, and then I can weave PFE into that process, and I can help make that case for them. So here's just another example that we wanted to show. So even looking at falls, we know that falls is a big concern for everyone throughout our network. So looking at this, 146 hospitals within that second HIN group that came together. The high performers that they're looking at here are 4 and 5 PFE metrics, and the low PFE performers are 3 or fewer. Look at that incredible performance that's showing that. You've got the HIN aggregate, the blue are the high performers, and the low performers are in red. But even among the low performers, you can see that that PFE influence is impacting their falls. And when they correlate that, when we look at falls, especially one of those areas that is so pertinent for engagement there, because a lot of the times the falls are happening not when we're sitting in the room with them. It's about whether or not when we're giving them the recommendations on, hey, please call for a nurse before you go and you do this. Or, you know, if they're using their socks, if they're going through that. It's what's happening when we leave the room. And that's where engagement comes in, because we have to have those built-in trust and relationships and those conversations to make sure not only do they understand what we're saying, but do they have vested interest? Did we say it in a way that makes sense to their goals of care for them to actually follow through on it? Because at the end of the day, it's impacting their health, but we're also being held accountable for those things that typically we have a little locus of control. So how can we increase that locus? And then again, we talk about the fact that PFE is about more than just being a feel-good. It's not just going to be something that, you know, we're doing to or for our patients. We don't want to call out satisfaction. We don't always want to call out that it's about the money. But we have to be real with one another and be transparent in the fact that patient satisfaction is a huge influence on our reimbursement, and it's something that we have to pay attention to. For example, we look at our HCAP, so our Hospital Consumer Assessment of Healthcare Providers and Systems. That assesses patient-reported care experiences. As we noticed, it influences our reimbursement, not only in the quality of care and the experience when we're looking at our Medicare reimbursement, and then also for some of the private payers, we kind of look at some of those methodologies that kind of interweave together, but it's also indicative of their satisfaction and their approval with their experience as they go through that. And so really what it's looking at is too, is that if they're satisfied and they have a happy experience, are they willing to choose our hospital again? Are they, you know, some of our folks are coming in just because it's urgent. They're coming in via ambulance because they don't have another option. They just got to go to the next closest place. But a lot of our folks are also making decisions on where they're going to go. And across our systems, not just even our hospitals, but even for those outpatient services and a variety of those different things. And when we're looking at if we're going to go to hospital A or hospital B, I want to make sure that my patients are having the best experience. So when they look at that, they're going to be more willing to choose my hospital A versus hospital B. And then the other thing that I think is really important, we talk about patient satisfaction, why we talk about HCAP. And I know HCAP is kind of a dirty word sometimes for some folks when we kind of look at that. But the thing that I like about HCAP is that it offers us some benchmarks, but it's peer established goals. So sometimes we get like kind of a commitment or a goal from CMS or another payer or some other federal entity. It feels like you don't know what it really looks like boots on the ground. Like you're so off base with that. But by having HCAPs and having those peer established goals and having those publicly available, it allows not only patients to be better informed and to make those decisions, but for us to look at our peers and to say, how are we competing and comparing across a network of ourselves? Which again is something that we do within the HIN already, but it also makes us look at, Iowa-wide. We can look at other hospitals in other states, and we can look at the national averages that we don't always have ready access to otherwise. So let's just take, for example, so here I've got the HCAP survey questions, and I took a random high-performing hospital within Iowa and a random low-performing hospital within Iowa, and it just so happened when we looked at it that they were within 35 minutes of each other. And so we were looking at this and saying, okay, so we're looking at our current considerations. What's the impact on our patient satisfaction? And the first thing that I saw was when we looked through our high performer, pretty typically scored higher on their HCAPs than the low performer. But when we looked at the low performers still, and we looked at the Iowa average, which is typically significantly higher than the national average, but we even look at those two, and the low performer is still performing higher than the Iowa average or the national average. So that was intriguing to us. It made us start thinking again, so what's going on with this process? Again, so are we just not capturing what we're doing? Or what's happening, especially when we look at, again, HIN nationally in our current performance. We know with the current HIN for Compass, we merged 2 states together in our hospitals. And if we've got some folks that are just starting off in the PFE process or are low performers or a variety of different things, or there was a switch up in the hospital, the person who was reporting it before isn't the same person, and the new gal isn't aware of some of the stuff that's happening, we know that that is going to affect our performance. So we're being cognizant of that, but we're also still looking at this and saying, oh goodness, we're still performing awful high. One of the things we think about, so look at those 2 HCAP survey questions. So patients who reported their nurses always communicated well, and patients who reported their doctors always communicated well. Well, those are 2 kind of, PFE questions that when I look at our metrics and I look at some of our performance on our PFE metric 1 and PFE metric 2, I want to look at our performance there. And if you look at that first one, we've got 87%, 85% between our high and low performer. So number one, we're looking at that and thinking, my goodness, well, we have to be having those conversations. I can't imagine patients are reporting that they always feel that their nurses communicate well if they're only having conversations at admission and discharge and not in between those times, that those nurses are not having those bedside conversations and not doing that during shift change. We look again at the reporting of doctors who always communicated well and still really high performance. I mean, even look at the national average of 82%. Our low performer is at 88%. Again, looking at, okay, so there has to be something that's happening and they're not acknowledging that maybe it is already going on. Maybe they're not calling it PFE. The other thing that we look at is you saw the high performer, 95% for the high performer. And when I look at that, one of the things I question, so for those that maybe they're hitting that PFE metric 3 and they've got a champion or they've got a functional process. So again, particularly with those physicians and clinicians where they have those limited interactions with people, is that the process that makes it to where that's happening with those docs, that's happening across the board that leads to those improvements? We look again also at the next step that's in here again, and we see again that continued process that goes in through here. So just one of the questions here, looking at patients who reported that yes, they were given information about what to do during their recovery at home. And I look at 90% for the high performer, not shocking to me, that makes it national the higher average. Then I look at the low performer, and that's an 86% in through there. Now, I'm wondering if they're looking at PFE metric 1, and if they're doing discharge planning and they're having those advanced conversations, do they have some of those things in place? And really, should they be meeting that metric, but they're just not acknowledging it? Look at the last one here. Patients who reported, yes, they would definitely recommend the hospital. This is a huge one because, like I said, these hospitals are within 35 minutes from each other. You look at that high and low performer, and you do see a difference there, 84% to 72%. So if that patient, their family member, has to make a decision if they're going to turn left or they're going to turn right, and it maybe is equidistant for them, where do you think that they're going to maybe go? And we got to think about that. So that's something to consider in mind, especially when we're making that business case with our C-suite and our leaders there. Another quick thing just to capture on here is we've got the HCAPs and we've got our South Dakota and our Iowa averages. Again, we are significantly performing higher than the national average, so that makes us question sometimes for our PFE metrics. If we're not always the top part of that when we're comparing to our HINs, what might be going on? Another area here with that second tier of those questions again with that. So just looking through those. So what are the current considerations? So when we look at our current performance, are we underperforming? Have we stopped doing things, or are there things that we're just not doing? or are we under-reporting? And so that's where we really want to focus. I'm going to turn it over to Stacy, and she's going to have a conversation with us about, again, what are our metrics mean? What are the ways that we can actually meet those metrics? And a lot of them are things we are already doing. For being in our hospitals and sitting there and seeing what's going on, we are confident to feel as though I think that these things are already happening. But maybe if they're not, maybe what of these alternatives are happening, and we need to capture that. So, Stacy, over to you.
All right, thank you. One thing to remember with these metrics, as we've stated before, is they're not black and white. It's not like a lot of the other metrics that we're reporting on, where you either had a COTI or you didn't, or the patient either fell or they didn't. There are really variant shades of gray here, which at times can make it difficult to determine if the action being taken meets the metric or not. But if you do ever have any questions or doubt about whether something meets those metrics, reach out to your improvement advisors. They can really help you determine the answer to that question. With that, you should be receiving this handout pictured here from your improvement advisor if you haven't already. Also, it is posted on the resource library on Innovation if you would like to get the information there. Basically, what it does is walks you through the metrics, what they mean, and looks at some of those first steps and alternative ways to meet them. We'll just kind of walk through metric by metric what some of those say.
And one question, since we've got our folks here and you guys are pretty active in the chat box, what I'd like to know, how many of you guys have actually seen this handout already? How many of you guys have received that from your QIO, or your QIA, or you've looked at it on Innovation? You just type away in the chat box. So if you can pop that in there, I'm going to let Stacy go on, but go ahead and put that in there. Have you seen this already, or is this brand new to you?
Okay, we'll take a look. For instance, metric 1, the implementation of a discharge planning checklist for patients to have a planned admission, known to have a planned admission. So really looking at that, are you doing it on at least one unit in the hospital? You know, maybe not hospital-wide yet, but are you doing it in one unit? The same goes for metric 2, with the hospital conducting all shift change huddles or bedside reporting with patients and families. Are you doing that in one unit in the hospital? You know, maybe initially, yes, ultimately the goal is to have these things rolled out hospital-wide. That is the intent. But sometimes that's a hard thing to accomplish right out of the gate. Maybe it's easier to implement these things in the beginning on one unit. And we need to acknowledge that those efforts are being made. If you're doing it in one unit, you're doing it. You're doing this metric, and you need to give yourself credit for that. Then taking a look at metric 3, as Katie mentioned before, this one is the designation of a PFE leader in the hospital. And through conversations with many hospitals, we've realized that they already unofficially have this person in their hospital. Sometimes we see it as the charge nurse or a social work supervisor or a patient experience specialist, or a lot of times it's the quality person. And maybe they just don't have that official designation yet, but can you make it an official thing where, okay, this person is going to be our point of contact in the hospital for questions regarding PFE. So any person throughout the hospital knows that they can come to them for that. It doesn't require a new hire or an entire new job description, but just some sort of designation that says, yes, this is our PFE champion. Then we move to metric 4. Metric 4 can be a little tricky. It is, does your hospital have an active patient and family advisory council? And there are different ways to meet this metric that still really get to the heart of what we're trying to do. The intent of metric 4 is that the hospital has a formal relationship with patients and family advisors. It may be difficult to form a PFAC at first, but could you have a patient or family advisor attend one of your meetings that is already in existence, your safety meeting or your quality meeting? It may be difficult to add another meeting to the calendar, but allowing your patient or family members to attend one of your existing meetings may remove that barrier. And it should be noted that on those committees, the patient and family advisor should have the same rights and privileges that other committee members do. And I do want to acknowledge that a lot of our hospitals serve an older rural population. So maybe it's difficult for them to make it into the meeting. So could you have them call in when you're having your quality or your safety meeting and give them that opportunity then to voice their opinion about things that are happening in the hospital or issues that have come up. And it doesn't even necessarily, they don't even necessarily have to stay for the entire meeting. If, you know, maybe there's things that you're discussing in your quality meeting that really they don't have any interest in. And we want to be respectful of their time as well. So can you set aside that time in your quality or your safety meeting for them to either attend the meeting or dial in and really get that voice and perspective from patient and families heard? Another option really would be, we'd heard an example of a hospital sending out surveys to their patient and family advisors, specifically regarding the questions that came up in their quality meeting. And that's another good option. Again, being respectful of your patient and family advisor's time, they don't have to come in the middle of the day for a specific meeting or dial in. They can fill out the survey and send it back when they're able, and you're still able to really get to the heart of that metric, you know, forming that relationship with your patient and family advisors. We had one hospital ask the question. They had an administrative advisory council, and quarterly their CEO would meet with that group and discuss updates in the hospitals and projects that were happening, and then it was an open forum for that community and the family and the patients to really discuss their opinions on what was happening and to voice that perspective. And the hospital was concerned, you know, it's not called a patient and family advisory council, so does it still meet that metric? And that's where we get into those shades of gray of, yes, that still meets the metric. The verbiage may be different, but the heart of the issue is the same. They still are forming that open communication with their patient and family advisors. They're forming that relationship and that trust, which is what the metrics are trying to accomplish. And then metric 5 is another one. This is one of the ones where we saw a little bit of that verbiage change. So do you have one or more patient representatives on the board of directors? Again, understandably, this may be difficult, but there are alternative things that we can do to meet that metric. For instance, if you do have a PFAC, you could have a PFAC report as part of your board meeting. They could come report out the things they're working on, the issues they're having, and really get that voice in front of their governing body. Another option is to identify a specific member who's already on the board and have them be designated as the voice of the patient and family members. This person is going to vote with that perspective in mind. They're going to enter into discussions with that perspective in mind, and that's another way that they can get that patient and family voice heard in those governing decisions. Another thing you can do is you can have your board members visit units in the hospital. Say twice a year they go out to a unit and they get to experience things from a patient perspective. How long are you waiting in the waiting room? What is the flow of traffic like? And really help them better understand how the decisions that they're making in that boardroom are affecting what actually happens to our patients. Again, I want to reiterate that the things in this handout are not a be-all, end-all. It's not a one-and-done type thing. These are first steps to begin those PFE efforts. But again, once these things happen, then we should look at next, okay, how can we spread this further? How can we take the checklist to 3 units in the hospital? So it's a very much a progression, but we want to make sure that we're giving credit where credit is due when these first steps are being taken. I'm going to pass it back over to Katie.
All right, so we've got some discussion here in the chat box. So I posed the question to the group, with Stacy giving this kind of these alternatives and hitting again back on that intent, is it changing the metrics and how we kind of view them and whether or not we meet them? So I'm getting great feedback here that, you know, for some of it's possible, it's getting the wheels turning to to think them over, particularly PFC Metric 5, which we know is the really hard one. And we've gone back and forth, we've advocated with you and say, okay, I get that language and I know that's what we like, but it's not real. It's not a real world application for us. And if it's not real world, then it's not really helping. And so that's where those alternatives come into place. So what I want to do is I want to open it up. I want you guys to continue. If you have questions, maybe for some of you that are on the line, what are some of the key issues that you're having? Or if you're struggling really hard with one of the metrics, which one is it? Again, this can be a practice. This is our safe space, like to be honest with one another and to learn what's kind of going on. And we might be able to brainstorm together on whether or not something meets. And if it doesn't, maybe there's a little tweak that we could do to help get us there. So as we're kind of sharing that in there, I want to issue us, to all of us, a call to action for us to review the metrics, look at the new language, look at the alternatives that are on there, and again, focus on that intent. And I don't want us, when we look at the metrics, to think right now, right off the bat, oh my God, what's my reporting? I know we're really focused on making sure we get our reports in every month, and we're going through that whole process. When we first sit down and look at it, okay, let's just think about what all this is. Maybe get creatively thinking about something that maybe we've met the metric, but how can we continue to enhance that? And what I want to do is, for some of us that we're looking at them, and for those, again, and I hate the terminology low performer, because we're all in a different stage in the game of PFE. It may be brand new, and so you're going through, maybe you're making amazing strides, but you just haven't gotten there yet because you didn't get started until later. But wanting to look at what's already happening in your hospital. So before we start to consider what's missing or what's new or what more do we have to invest in it, let's look at what we're already doing. Let's look at those resources and those commitments already in place that can help to build off of that. What's the foundation that we already have in place? And to really look at both those formal processes, as we know that those are necessary to really look at sustainability, and to take anything, whether it's an evidence-based best practice for, look at CoP and whether or not we're doing Foley catheters, you have to have a process in place to make sure that it doesn't just become a one and done, or something we were really excited about it for a couple of months. We really hit on it hard, and then another fire erupted. We went this direction, we had to go somewhere else. So want to make sure that we put those in place and we acknowledge that influence in taking something from an episode into a systematic approach. But look at your informal operation. That, to me, particularly whether I'm talking to a hospital, a clinic, if I'm talking to anyone, we go through and we look at the informal operations is really where PFE speaks. Because I care very little about whether or not you have a banner in your office or in your lobby that says, oh my goodness, we love our patients, we're all about our community. I care very little about that. It's the experience of care and how we communicate with one another, both me as a patient to my providers, and also as providers back to me, and also as me as an advocate and as a professional. Unless those things are happening in those small episodes and those small instances, those big things don't mean as much. It's those small things that a lot of times we're doing already that lead to the biggest impact. And we want to capture and acknowledge the work you're already doing. The intent for this, at the end of the day, we want to be high performing. We want to check those boxes. But if we're not really doing those things, I don't want to check that box. I'm not about that. Because at the end of the day, if we check that box but we're not really doing it, we're not going to see the impact. We're not going to see that influence any of the other things that we're working on that we care about. And so we'll lose investment. It won't matter as much. So let's capture what we're already doing. And I just want to share here some of the conversation that we're having here is that, we're hearing that especially the buy-in from nursing bedside shift report, they don't want to do it. We hear that all the time. And that's a very valid and honest thing, because it seems like it has to be this extra thing. When we've worked with our hospitals and we've done coaching, what I've done is I've sat down and said, okay, so how are you currently having conversations with patients? When are you talking to them? What are you talking about? And sometimes what it is when they're doing that, they're already there at that bedside. And they're having some of that shift. Some of it's, okay, we're not doing it at every single shift change. We're doing the huddle out in the hall, especially if it's an overnight because the patient's sleeping. And do we wake them up? Do we go through and do that? But if you're having issues with that buy-in investment, sit them down and let them hear their voice again to say what they're currently doing. And you might be able to call out that, say, oh, but you're already doing it. You just thought it was something different. Or, okay, so you're doing that like this, but we tweak it just a little tiny bit. And particularly anytime that you have data, especially for that floor, that unit, to show that we've had issues lately with falls or, adverse drug events or a variety of different things or infections or any of those, tie it in with that. and acknowledge with them and say, we get that you are trying to take control for everything, but we also know that some of the stuff that's happening is happening when you leave the room. And so how can you make sure that the people that are left in that room, the patient family included, are going to be able to follow through on those things? And then we've also got a report here that we've just changed to bedside reporting and recently had a patient condition change, that the nurses were able to implement care for this patient earlier because of the bedside reporting. That's amazing. And
Great.
Those are those things, again, that we want to call out that success, but make sure, too, you're calling it out with your staff and you're sharing that. And that's the point of this community of practice here, where we have these conversations where one person's saying, oh, we keep having this issue, and say, oh, I have the same thing. And we didn't really get that buy-in until they got to see it firsthand. So being able to share that story, but let them know and say, I get it. Like, there's enough, it feels like another thing on the plate. Be transparent with that, but say, you know what? This is really what's impacting. We're going to have another thing on the plate regardless. And it's just whether or not we get to do this and be proactive, and it's an easier lift than having to deal with the adverse events after it happens. So something's going to come on. The idea that we're not going to have an extra thing on our plate in 5, 10, 15 minutes, that's not how our lives typically work. We kind of know that. So being able to be, you know, straightforward with it, but also make sure just to frame that and turn it around to say, it's a lot easier for us to have that conversation and to make sure they're engaged with that, rather than we leave the room and something happens along that line. So I think that's great. So that's awesome. Yeah, and nurses and aides, the managers, again, we talk about person and family engagement, and we have got to walk our talk of engagement. And it is not just about the patients. When we talk about person-centered care, it is about a team-based approach. Now, that team includes the patient and the family, and that has roles and responsibilities for them as well. It's not just for us to make sure they have a hotel-esque hospital experience. But it's also, there are roles and responsibilities. It's not just all the physician, it's not just all the nurse, but there's roles and responsibilities that happen for the lady who's sitting at the admit desk. There's a role and responsibility for the janitorial staff that are coming in and out of there. Engage every single person. There's a role and responsibility for that CEO. And again, that's why it's so important that if, say, the issue that you're having is leadership investment, and how do you frame that? And then again, why we do this HIN thing together is we recognize, you know, we have skill sets and we have subject matter expertise that we can coach and we can do that, but we're all still kind of along the same curve, on a learning curve together, trying to figure out how we do this. We're in the process of transformation as a partnership. And so being able to call that out so that we can support and help do that. So call to action, so to review all the metrics, look at what's already happening with your hospital, and get credit where it's due. Pat yourself on the back. And the last thing that we kind of go through is, again, something with Stacy and I, is that we want to issue a challenge for us. So not only to informally acknowledge the work that we're doing, but once you've reviewed the metrics and you look at them and kind of think them over and think about them critically and creatively, think about what you've done with it, then make sure you're going in and you are reporting what you're doing, that you're capturing that. A lot of folks, when we talk to our hospitals, and Stacy can kind of elaborate on this, they're saying we're doing this, this, or this, but we didn't hit that mark because it was only in one unit. Or we didn't hit that mark because we've got a discharge planning list, but we don't have pre-scheduled admits. So we don't do that. But I mean, if we did have an admit, the times that we have, we did talk about it in advance just because it was such a unique experience. Or the fact that, yeah, we brought patients in for this one activity. We kind of do it on a special projects basis. We don't have a standing group at any time, like if we're going to do a lobby redesign or our patient education materials or this or some of those different things, we do those. So make sure that even if you're doing them in small increments, you're capturing that. So Stacy, anything you'd like to add?
No, I think that covers it. I just want to reiterate that I think we really are doing wonderful things. It's just, now it's just a matter of capturing all of them.
And if you ever, question, oh my goodness, I feel like we're just checking this box, look at your HCAP. I promise you, none of our hospitals, when we look at them, especially compared to our state and national averages, you will not be disappointed for the most part. When we look at those, especially the communication aspects and those that are talking about whether or not they felt as though they knew what to do. So we talked to them when they had a medication change. That was a huge one if we went back on that slide, but there was a huge difference in between there, and to look at that and to say, oh my goodness. Sometimes with PFE, it's really hard to see that immediate win right in front of you. So look at that, reinforce the positives as much as you can and wherever you can.
And I do want to emphasize that your improvement advisors really are here to help. If you do have those specific scenarios, run them by them. They can really provide a lot of guidance for that.
And just because our COPs and our events never run by themselves, here's kind of what's coming up. So Stacey, we have a learning community that's coming up?
Yep, Compass HIN has their learning community coming up September 26th. It will start at 8:30, and that's going to be at the FFA building on the Ankeny DMAC campus. We're going to be looking at a lot of topics kind of revolving around sepsis. So that'll definitely be one not to miss.
Yeah, I think what's important is when you come to that, that learning community, you'll kind of see too when we talk about sepsis, that's kind of our clinical topic, but there are going to be aspects of a variety of other things that filtered in there, such as person and family engagement. How do you go through that? So you're like, when you're listening to those stories and we're going through, we always are kind of checking that to see kind of where it's hitting and what's going on with that. So just a reminder, there's a registration link that's on there, but you can also register on Innovation. And we will also, again, we always record these and then we post them. So we will post the slide deck with it. And then also we will post the handout, the one-page PFC metric handout that Stacey covered on there, because we know some folks have seen it, which is great. They got it from their QIA. And others of you, this was kind of the first go round. So we're glad that we got to go a little in depth with that. So the other thing we always like to recommend for you guys is to reach out. So we know hopefully you maybe take this COP and you have some of your other staff members look at it and share this. But if you have questions, or if, reach out to myself, my contact information is there. You've got Stacey connected on there and your quality improvement advisors. And reach out if you're having a question, if you're having a big challenge or burden. It's not only something that we can help coach through the process, but we might have some additional resources or additional contacts or thoughts that we can kind of build in there together. So don't be afraid to reach out, or, if you've got something to celebrate, something really awesome just happened, we like to promote you guys and share and really be your cheerleaders more than maybe anybody else outside of your hospital. So we want to hear those successes, whether they are small or they are large. So before we wrap up here, we've got a few extra minutes, but what I want to do is just open it up for any questions that anybody might have. So we're going to do a quick unmute of all the lines here. So just again, remember, if you want yours muted, make sure you hit mute, not hold. But any questions or comments or anything anybody'd like to share? We've had good chat discussion, so everybody's unmuted now. So gang that's on the phone here with us, how about you guys? I mean, I know that we've got a couple that with the alternatives, you're looking at how you're changing, how you might be reporting or anything. Anybody got any specific metrics in mind that it really kind of got them thinking and their wheels turning? Kind of a quiet group today. Okay. Well, I know we had good chat conversations, so we won't call anybody out and make anybody speak here on the line in person, so we'll be nice to you today. But a reminder that this is recorded, and we will be posting it along with the transcript, the slide deck, and then also that handout, so be sure to watch Innovation. Make sure you're registered for the September 26th learning event, and then reach out and communicate and be prepared to have us be touching base with you. So hope you all have a great day, and until next time.